Good morning to all. I would like to give some of the glimpse about our recently published article in Rural and Remote Health Journal on status of coverage of measles and rubella vaccination from a remote rural area of South India. The title of the study is Status of Coverage of MR Vaccination after Supplementary Immunization Activities in a Rural Area of South India, a Rapid Immunization Coverage Survey. Even though cheap and effective vaccination for measles is available, every day measles kills around 360 children worldwide. Measles is considered as the leading cause of death among the children, and rubella causes fetal death and congenital anomalies. Measles eradication was planned in 1980s after the eradication of smallpox. However, WHO concentrated on polio eradication first. After commendable achievement on polio-free Southeast Asian region by March 2014, WHO is now focusing towards the measles and rubella elimination by 2020. As a part of this initiative, India introduced MR vaccination in the routine national immunization schedule as 2 doses, first in 9th month and second in 16 to 24th months of age. In addition to attain the minimum 95% of herd immunity level in the community, supplementary immunization activity was launched to vaccinate the children between 9 months to 15 years. On the other hand, there was a negative campaign going on in the social media against this initiative. Even then, India has introduced its one of the world's largest immunization campaign on MR vaccination with an aim to cover more than 95% of the children between 9 months to 15 years. India introduced this program in a phased manner over 4 phases in 36 states including 7 union territories. As a part of phase 1, this has been first implemented in the highly performing southern Indian states including Tamil Nadu on 5th April 2017. So immediately after phase 1 of MR vaccination, we have planned to assess the coverage of MR vaccination in our rural service area using a standard WHO technique, that is 30/7 rapid monitoring method. In this method, we are supposed to select 30 clusters or villages and 7 participants from each village. So in our study, 30 villages around our rural health training center were selected and 7 participants from each village were selected randomly. Our main outcome was status of vaccination, and in our study, children were classified into vaccinated or not vaccinated based on the vaccination card and or vaccination mark in their finger and or information from either of the parent. This is called WHO history or card method. Important finding in our study was with a total sample of 420 children, 380 children were found to be vaccinated and 40 children were found to be unvaccinated. This main finding of 90.5% of coverage correlates with the government report at the end of the campaign, which was claimed as 96%. The main reason for not getting vaccinated was fear of adverse event following immunization or fear of injection. Actually, there were several rumors circulating in the social media warning the parents not to allow their children to get vaccinated. Even minor adverse event following immunizations were magnified in the media, adding public tension. Despite various negative propaganda disseminated in the social media against this vaccination, the coverage of vaccination by the healthcare providers in the rural area was near optimal, which shows that the strength of public health system in rural area of South India. In our study, we also found that those who are using smartphones were associated with not vaccinating their child and less acceptance rate. This is called vaccine hesitancy, which is common for both developed and developing countries. Similar findings like our study were also reported from few other studies from India. Lesson learned in this campaign was in accordance with the modern technology, public health policymakers should think and plan IEC activities to tackle the negative propaganda through social media. Strengths of this study were, this study has been done immediately after the phase 1 of MR vaccine campaign to know the coverage of vaccination in the rural remote area of South India using a WHO recommended method. The survey was conducted independently, which makes our observation free from reporting bias and conflict of interest from government agencies. This is the first study report the coverage other than the government reports. One of the limitations in our study was we relied on the history and our vaccination card and our finger mark for the confirmation of the vaccine, which is not as robust as confirmation with serology. As a way forward, we recommend to assess the coverage based on the serology for better validity and mixed method to understand the perception of the people better. To conclude, the coverage of MR vaccine in the rural area of South India were near optimal during the phase 1 of MR vaccine campaign. We hope India will successfully complete this world largest campaign and join with the countries which have already eliminated measles and controlled rubella in Southeast Asian region of WHO. Thank you.